we have Dr. Vanathi, and she'll be speaking on two topics. When if you get a wound burn, see the wound burn with all those newer phaco machines, the amount of energy used has come down, but with the use of something like Viscoat, which actually blocks that phaco tape, we are basically bothered about the energy that is used for the nucleus. We are not bothered with it, but wound burn is a very nasty thing to happen. So you have a patient with wound burn, what to do. Dr. Vanathi will be speaking on that. And another important topic that she'll be speaking on will be what to do if you get a very hazy cornea on the first post-operative day. One thing.
Thank you, Srini. So I think two very important post-operative conditions or two important complications, concerns which can occur, especially in people who are in their early phase of cataract surgery, is hazy corneas. One is post-operative and hazy cornea at the wound which can occur where you're operating here. No financial interest. So I'll first take you through hazy post-operative corneas, what can be next here. I think my subsequent speaker is going to be talking about inflammatory causes, so I'm not going to touch the inflammatory causes which are going to lead on to a hazy postoperative, but something which is very common is the Descemet's membrane detachment here. So postoperatively, how do you recognize it? You have a corneal edema or corneal haziness, which is not in proportion to the whatever events to an uneventful cataract surgery here. So that's when you would probably have a Descemet's membrane detachment top on your list to look at and see if that's what is causing a postoperative hazy cornea here. So important is to recognize those corneas which are at a risk for occurrence of intraoperative or Descemet's membrane detachments or Descemet's membranes which can detach and lead to hazy corneas postoperatively here. Commonly in old age patients here, they have Fuchs endothelial dystrophy, that's meaning a pre-existing poor endothelium, hard grade of cataracts here. And when you've landed up using an increased phaco power in these patients and uncooperative patients, these are the common scenarios which would lead to such a postoperative corneal haze here. When the haze is localized and limited, meaning your Descemet's detachments is shallower and it's only probably involving a particular part, commonly it involves near the wounds or near your stab incisions here, and you would be able to pick them up on your slit lamp evaluation here or have a high index of suspicion. It's good to take a mount for an anterior segment imaging with an ASOCT to look at the configuration of the Descemet's membrane detachment here, because recognizing the configuration, it's probably going to help you in a more successful management of your Descemet's membrane detachments. Shallow detachments localized to one particular point, not associated with any tears. They are planar detachments. They are not non-planar. They are not having scroll drop edges. Then it's very easy to settle them up, and some of them probably do just settle with conservative medical management here. But when you are having scrolled edges here, and when you are having regmatogenous detachments, or you're having a tractional detachments, I think this is more for completion of sake here. You have a significant amount of different types of classifications which can help you to categorize these detachments here. But one such which has evolved from India here and is highly quoted is the HELP algorithm, the height, extent, length, and the pupil based algorithm, which could probably be a better guide to enhance your management of Descemet's membrane detachment in the postoperative phase. I think it's largely quite simple, and you really don't, I really do not refer to these. The simple dictum is you find it, wait for a couple of days here, and you find it's a more bullous detachment involving a larger area, threatening to involve your central cornea. Then you would probably go in and intervene as soon as possible here. Some of these are publications which do talk about the configuration or the associated scarring, especially in cases which you need to take on for endothelial keratoplasties here. So what you need to do when you're looking at conservative managements is you step up or you enhance your medical management in these cases here. When you would want a rapid visual recovery, then go in and bubble these cases. You can have simple pneumatic desmatopexies with air or with gas here, which provide a mechanical tamponade, and you can enhance it along using a transcorneal fixations here. Very large ones would need desmatotomies if there are tractional detachments here. So this is a short video here. You can see a very localized Descemet's membrane detachment, which is there in this particular case here. The rest of the cornea is looking relatively clear here, and these are scenarios where you would probably go at the opposite end, 180 degrees opposite, and then bubble the Descemet's membrane and allow it to settle. If you do recognize it intraoperatively on the table, then it's much easier. Instead of leaving fluid to fill the interior chamber, you could just leave air there. And again, a simple tip is not as this, don't allow a lot of fish egg appearance here. A single large bubble is more effective when you are trying to manage a Descemet's, doing an air injection into your anterior chamber for management of your cases in such cases. For gas, it's if you're having repeated detachments, you're having larger detachments, and you want your tamponade to be on for a longer period of time, especially in one-eyed patients, then you would probably go in and use your SF6 or C3F8 in these patients. But please do take caution that these patients should not be flying in their postoperative period here. It's a simple tip on how you would go about mixing your isoexpansile or non-expansile, 20% SF6 or 14% C3F8, and that really helps you, and you're sure that you're not going to have problems because of your gas bubbling in these patients here. And several times it's better done yourself to dilute rather than looking at your scrub nurse to take care of your dilutions, because improper dilutions can by themselves lead on to further problems in these cases here. This is when you're having a detachment, a scrolled edge, a large one. A simple bubble is not probably going to help in settling here, and that's when you're going to need your transcorneal fixations here to augment the settling of the Descemet's membrane in these cases. So once you've gone and bubbled in at an entry 180 degrees from the axis of the a Descemet's membrane detachment, a simple suture through and through involving the detached Descemet's will go a long way in settling up these cases here. And here you can see once you've bubbled it, you do have some amount of fluid which is collected in between the detached Descemet's and the stroma. That also needs to be released or needs to be stroked out for enhancing the or better settlement of the Descemet's membrane in such a case. So this is why yet another case of Descemet's membrane detachment, which has a scrolled edge or a detached edge at one corner where you can enhance using a transcorneal fixation. Last but not the least here, this is bullous detachments, which are a limbus to limbus, and they are particularly refractory to repeated bubbling in cases here. And this was one such patient who had come with the three bubblings done outside and not effective at all. So what we did found on an IOCT microscope is that there was a large fluid collection. I'll quickly run you through that video here. There's a large fluid collection in this patient here, and that required intrastromal vent incisions to release the fluid. That's the configuration of the bubble, of the detachment, a hazy cornea sitting there. So go in, bubble here, and you have an IOCT. You could see that you're in the right plane and you're not damaging and not going in the space between. You have to see you're going in the space between the Descemet's and the iris, and not between the Descemet's and the stroma here. And once you've bubbled, you go in and also put in interstromal vent incisions to release the fluid in these cases. So you'll have to be again careful when you are releasing that you do not implant epithelial cells into your stromal vent incisions. Those themselves can have problems if you're going to introduce epithelial cells into your stromal vent incisions here. To enhancing further, especially in chronic bullous detachments by intrastromal vent incision is another maneuver in chronic detachments which need corneal clearing here. So the points to remember is to identify, either it's best done when you identify it on the table, and if you have identified early in your postoperative phase, then depending upon the configuration, and early intervention helps in rapid corneal clearing and the settling of the desmus membrane, avoiding the need for further procedures like endothelial keratoplasty here. So I'll just quickly go on in the interest of time, just a couple of slides on wound burns. I particularly have not faced much wound burns even during my learning phase here, but a word of caution is, when does it occur? When you've used high phaco powers here, excessive frictional movements, because the irrigation sleeve is either too tight or the amount of fluid irrigating your phaco tip is not adequate here. Obstruction by viscoelastic devices here, these could be the commonest causes here. How would you work on preventing them? Be careful about the amount of ultrasonic energy you're using to phacoemulsify your cataract, and learn to calibrate and tighter the energy depending upon the density of the cataract you're doing, with frequent fluid cooling of your phaco tips here. Modifications of your phaco tip devices are some tips which can help you manage or avoid a wound burn here. Once you had a wound burn, how would you go about managing them intraoperatively? Then forming the chamber becomes difficult here. You're going to have leaks here. So suture augmentation or suturing your wounds, radial sutures usually could land up with higher astigmatisms in these scenario because of the scar induced. Horizontal mattress sutures work well in such scenarios here. Or secure the wound, you could use a BCL with a with a glue application, and sometimes severe burns might need amniotic membrane grafting over the wound area as well here. Add on topical anti-glaucoma medications and antibiotics to keep your pressures low and also prevent infection in these cases. If the wound burn is very large, then you probably will have to resort to other tectonic procedures for reconstructing the surface at that particular region here. This is another picture which clearly shows, which has been augmented by sutures here, and which heals with the scarring here. And ASOCT can help you to look at the configuration. The particular complications which occur is delayed wound healing, sometimes fistula formations, recurrent leaks, iris prolapse, astigmatism because of the scarring, and infection of the wound. I think I'll stop here, and thank you for your patient hearing.
Thank you, Vanathi. See, mm, when you put air uh, for for the distance membrane detachment, when do you actually take off the air?
Pardon?
You put in air to represent the distance membrane. When do you take it off?
Um, Normally, when I see a simple shallow detachment in the periphery, so it's a planar detachment. It is very shallow. It's not involving the pupillary plane. The rest of the cornea is clear. Then take them for medical management and wait. I normally wait just for 2 or 3 days here, and
No, no,
then
no, no, no. After putting in air,
after air, when do you
release the air.
when do you release the air? So I normally do not, for a descemet membrane detachment, and if they are smaller detachments, I do not do a complete air fill in these patients. So I do a 2/3 air fill and dilate your pupil a little here. So that is not going to cause a pupillary block glaucoma in your patients here. I would not want to go in and add a PI in these patients commonly here. So a 2/3 air fill, and anyway you are adding them, most of them you would put them on anti-glaucoma medications as well, along with the midriatic. So I don't go in and tap and release after.
Yeah, I do, because I do a complete air fill,
Okay.
and I've had at least two cases of
Yes.
pupillary block, so I release them after maybe 2-3 hours. Otherwise,
You're particularly safe if you do a 2/3 fill here and you dilate, so that the inferior margin has you have a place where your aqueous is flowing through. Then you normally do not land up with a pupillary block.
yeah, and one more thing, like I've seen videos where they're putting in air using a 26G needle. It doesn't really work. See, you already have aqueous inside. You want this to take the place of aqueous. So what ma'am has showed, and she entered with the side port slit knife. So that gives the chance for the fluid to escape and the air to take its place. If it is 26G needle, it's sealed. Uh, then repeatedly you have to inject. Air won't go in. So then again you inject. So I mean, for me, I think it's better not to go in directly with a 2016 needle. Enter with and you make a partial entry with a keratome, then you can do it. It doesn't matter how much is going to be 1.5 millimeter. It doesn't matter, but you just have to make sure that you're doing it at the right place and not into the detached area, to go opposite to where the DM detachment has happened, and then do it. Umesh, anything to add?
I think the wound burn thing nowadays phaco power most of the time because we are using modulated energies.
Yeah.
So that is most frequent is the blockage because of the visco.
Viscoat.
So
Yes.
first thing, the
I mean,
moment you think about that and just do that, I think you'll be safe.
It's also good to,
And it
once you
occurs in
start.
just milliseconds. Once you don't have time also, so make sure that the blockage won't occur.
no, that is the reason why, like, it's you protect the endothelium with viscoat, then put whatever helon or
It's also
yeah.
good to, the first 10 seconds you're just anterior to the nucleus,
Remove
and
the
you do
visco
a
in the.
little aspiration and provide a space where you've taken out your ring and allow the blockage to go away, and then you go ahead and do.
Yeah,
You are
that one
usually
thing
safer.
definitely prevents wound burns.
In a phaco-fragmentation, generally we do not have a sleeve. So even if we are doing a small gauge fragmentation, unless we are doing through the ports, which are through the cannulas, there's bound to be, even with 23 and 25, we need to suture.
Thank you.